I'd like to introduce Dr. Greg Snepper. I know most of you know him. He's one of our pediatric anesthesiologists here at the Surgery Center. He's been an important member of our evidence-based practice project team. He's been instrumental on the front end with education and practice change guidelines in the prevention of emergence delirium. And you know that's really been our baby for the last couple of years to try to help with that. He's worked with the entire anesthesia team to improve outcomes in this population. He's taken an interest in helping the PACU team develop critical thinking and interventional skills to prevent long-term issues with our pediatric patients and to help patient and parent satisfaction and nurse satisfaction. So we welcome him and we thank him for taking his time to help us with this subject. And since we do have it videoed, please tell our other staff members about it so that they can look at it also. Thank you.
Thank you, Brenda. So I was planning for this mostly to be informal and kind of conversation with you guys. Didn't know that I was going to be a YouTube star, so I'm going to try to pretend that I'm not being filmed. But anyway, I think this is a topic that I feel like it was maybe a year and a half ago, can't remember exactly, but just randomly one day Brenda asked me about emergence delirium. We got to talking and she told me that she was interested in an education project about it. She's working with Lisa Clark, and so we kind of all got together, and I was definitely happy to help them with that because I think it's something that can be really challenging, it can be really stressful, and so I definitely want to lend a hand in helping you guys, both with your experience with it and then also the patients and the parents, because when it happens, it's not a very fun thing. So what I'm hoping to do today is just go through again some of the risk factors that we see for emergence delirium, some of the things that we do pre-op and intraoperatively, and then if it does happen, some things that you guys are probably already doing in PACU, but maybe we can re-emphasize that. And then also answering any questions that you guys might have about the topic. When emergence delirium happens, I feel like we could probably all do a pretty good job definitely noticing it, but it can be very challenging to tease out, when a kid's really upset. Is it actually delirium, or is it something else going on that could maybe be causing their agitation or them being upset? Kids can be upset for a lot of reasons, right? Sometimes it could be pain, sometimes it could be they don't like certain monitors on, or sometimes it could be being disoriented, or sometimes they don't like the IV, or sometimes they're hungry or tired. I don't know, and lots of reasons why kids can sometimes be upset. Why it's important, so there's kind of double-edged sword for emergence delirium as far as, on the one hand, thankfully there's nothing that's going to acutely harm the patient when they're going through emergence delirium. So I think it's nice to reassure parents when it is happening, because they don't know what's going on. They can be really stressed out that nothing bad or harmful is going to happen to the patient. On the flip side of that, we do see that there are consequences down the line. So it's not just totally a benign issue where if we don't try to either pre-treat it from happening or treat it when it's happening, it can definitely lead to other consequences. So one thing that we do see with emergence delirium, when kids have it, they are at higher risk for when they leave the hospital having behavioral issues that can last anywhere from hours to days, to less commonly weeks, but there's even reported instances where kids can have behavioral problems up to a year after having emergence delirium. And some of those things can include just maladaptive behaviors, temper tantrums, increased anxiety, like separation anxiety, and then they can also have things like increased incidence of things like bedwetting as well. So again, it's important. It's not just something that's totally benign. Again, in some sense, it is benign as far as, nothing. There's nothing I'm worried about as far as their heart or the brain or anything like that. But there can be down the road some other consequences that really affect the kid and the family and the parents. As far as risk factors for emergence delirium, so it does seem to be age-related. Not everyone fits in that category, but you're going to be a higher risk for kids that are age 3 to 7. Kids that have a pre-existing anxiety or behavioral issues are going to be at higher risk for having emergence delirium. Parents that are anxious may put their kids at higher risk for that as well. There's certain types of procedures that you can see a higher risk for this procedure. ENT procedures, which we don't see as much these days, but also eye surgery and then dental surgery. So we certainly see a fair number of those cases here. How the kid goes to sleep can be a risk factor as well. So we do several things to try to have the induction of anesthesia when the kid goes to sleep be as smooth as possible. And so we do that with a number of tools that I think most of you guys know. So sometimes that's just distracting with things like different toys, both when they're here in the pre-op area and then especially as they separate from parents, and then also in the operating room. You guys, I know don't get much time back there with us, but as much as we can, we try to do like games with kids as they're going to sleep with the mask, because that can be a very terrifying moment for kids. Sometimes we're more successful with that than others. But the other thing that we commonly do is give things like Versed pre-op to act as an anxiolytic again, on top of those other things we do. And usually I feel like if the kid goes to sleep smoother and less traumatic, they're much more likely to wake up that way as well. And then intraoperatively, some things that we do are the use of Precedex, I feel like is really helpful. One thing that I think would be good to pass on to you guys, and I've noticed this here as well, is that depending on the provider in the OR, sometimes that Precedex dose can be given at different dosing times, and also the amount can be variable. So usually when we talk about prevention of emergence delirium, the dosing is going to be anywhere from 1/4 to 1/2 mic per kilogram for those kids. And I also feel like I see if that dose is split up and it's been quite a while between they've gotten especially the dose of the Precedex at the beginning of the case, it's going to be less effective. I don't always do this, but especially for kids I'm going to worry about delirium, I'll try to mention to the CRNA to give that dosing at the end of the case when they're going to be going through emergence, so it's on board when you guys see them in recovery. But I think one thing that's important for you guys to think of is not only, well, has the kid already had Precedex intraoperatively, but maybe the dose and the timing of it. Now, if it was like a 2-hour dental case and they got half of their Precedex at the very beginning, then it's very likely that's not going to be on board when they're going through the emergence process with you guys. And kind of along the same lines, I think, another treatment for emergence delirium, both intraoperatively but also postoperatively, you can use narcotics, so things like fentanyl is probably the one that we use most commonly. But that's something also I'd encourage for you guys to think about. Not only, did they get narcotics, but also the timing and when that was given in relation to when you're receiving the kit. So you guys can tell me, do you feel like you get that on report very often? I know you get a report of all the meds that the kid got, but do you feel like they often tell you like when the doses were given? Okay.
Yeah.
Okay. All right. That's also something, when we'll get into the diagnosis here in a second, but sometimes it can be hard to tease out if, the kid's really irritable. Is it pain related, or is it more a delirium picture? And you know, if you're not sure, I always like to look back at the record and see, okay, when was the timing of her meds given? And if one of them was given a while ago, that might be the one that I choose to use first, just because that might be what they're missing in that moment. Does that make sense? Yeah. Okay. So other risk factors for having emergence delirium, the type of anesthetic that they receive in the OR can put them at higher or lower risk. So sevoflurane, which is probably the most common anesthetic gas we use to keep people asleep, is at higher risk as opposed to things like propofol. So you can still see kids wake up with delirium if they've had propofol as a continuous infusion, but it's probably less likely. I know some providers will run propofol as a background infusion, or at the end of the case they might even turn off the gas and just wake them up on propofol. I feel like I probably see that more at Mission than I do here. But those kids may be at decreased risk of having delirium. And then as far as diagnosis, so that can be something that's very difficult to tease out. Lisa, before she retired, and Brenda have worked really hard on creating a way that or a scale that we can use to try to help tease out that diagnosis. So I think Brenda mentioned that you guys have these placards now that go through, it's a CAPD scale.
It's being built and put into Cerner.
And it's being
currently.
built into Cerner. Brenda thought that these are actually on the workstations in Packy. You guys know?
Not yet.
They were for a little bit.
They were for a little bit?
Yeah, they were.
So we can, I mean, I feel like that'd be pretty easy to
I don't know where
do.
they went to.
She handed me this today. But again, delirium can look like a lot of things. Again, kids can be upset for lots of reasons, whether it's pain, or like I said before, an IV, or maybe they're hungry, or they just don't like being in the hospital, you know, they want to get back home. So to help tease some of those things out, there's a scale, it's called the CAPD scale. So it stands for Cornell Assessment of Pediatric Delirium. It's very similar to the PAED scale, which is the Pediatric Anesthesia Emergence Delirium scale, but it has a couple more questions added on to that scale to help identify kids that have emergence delirium but are in what I would describe like a hypomanic or a hypodelirious state. So instead of having a lot of agitation activity, they have more like under activity, I guess I would describe it. To be honest, I don't know how often I've seen that, or maybe I just haven't recognized it in a perioperative setting. The scale's also used sometimes in the ICU to help identify delirium. The CAPD scale, I don't know, do you guys want to pass this around? Do you want me to read through the questions so it's on the video? I mean, it should be pretty easy for people to find. The biggest things on it, so it asks if the kid makes eye contact, are the child's actions purposeful? I think that's a really key one. You know, can the kid identify what it seems to, you know, be bugging them? Is it, you know, can they point to the ID? Can they point to, like, you know, where they had some dental work done? Or does it just seem totally non-purposeful? Is the child aware of their surroundings? Do they communicate needs and wants? So those are all scaled from anywhere from 4 to 0. And then that scale is inverted for the next set of questions. Is the child restless? Is the child inconsolable? Is the child underactive? Very little movement? And does it take the child a long time to respond to interaction? So once you've asked or ascertained those questions and you can score it, it's very likely that the kid has emergence delirium if they have a score of 9 or above. So that's one thing that you guys can do to help define that diagnosis. And again, sometimes these things can still be difficult to tease out. And then this paper,